control. Please go on.
Yes. Thank you very much for all the organizers, dear colleagues, dear friends. It's a great pleasure to be here and to stay till a bit late in Abu Dhabi to be with you. The topic will be today acute to chronic. Are we in control? It's a bit challenging questions that I'm asking because I don't to be like accepting this concept of fatality, of being anesthesiologist and not intervening on this transition between acute to chronic pain. So my first slide is no disclosure regarding my lecture today. I'm just the founder of the Gulf Pain School and the current president of the Gulf Pain Society. So pain after surgery, we know that acute pain can be nociceptive, can be neuropathic also. Neuropathic is not only chronic, but this transition of acute to chronic persisting pain is defined as the pain persisting longer than the healing time. Healing time can be very variable, and 3 to 6 months are the time and delay that are commonly known and commonly accepted from our community. So I'm gonna take you for a small journey from this acute to chronic, starting with some questions and some like challenges. So how serious is the problem? So we're gonna go for some epidemiological studies and data. Why does it occur? We'll talk about pathogenic mechanisms and some of the reasons and the pathophysiology, and to ask ourselves, are we in control of these pathophysiology? We know that the physiology will become pathological, and the pathophysiology after this transition from acute to chronic will be a real challenge, and we'll see if we can be in control of this transition. What can we do? I'm going to talk about prevention, of course, and treatment if possible. We'll start with the post-operative pain, the acute post-operative pain. We know that we are not doing very well. We know that almost 80% of patients undergoing surgery experience post-operative pain. And when you look at this pain, less than 50% will report adequate pain relief. So we know that it's very striking and very difficult data to accept by us as anesthesiologists. But the majority of these patients, and we know they still declare, they're still telling us that moderate, severe, or extreme pain in the majority of these patients. The most important part in our topic today is that in this data, we had like 10 to 50% of chronic patients, of chronic pain. These patients are suffering for a long time, and not only chronic, severe pain occur in 2 to 10%. And these patients, we see them in our pain clinics, and they are very difficult to treat, very difficult quality of life these patients are having. So it's a real challenge for us. More importantly, when you look at what's going on now in the trend for all these ambulatory surgery, day surgery, pain becomes or is the most important element for readmission of these patients. So 38% of these patients will come to or be admitted in the hospitals because of failure of treating the pain. When you look at the literature, and this is a very interesting paper from Germany, some time ago now, 2013, showing that when you look at this number of patients that you have here, lots of surgeries, lots of patients, more than 7 million patients, they have been gathered in this paper here. The majority of these patients that are seen in this data are well treated in major abdominal surgeries. We know that we are prepared. We know that we can do something for these patients for major. But when you look at the appendectomies, cholecystectomies, the simple surgeries, it's very, very striking that these are the surgeries that are not well taken into consideration, and the pain is very high in this case here. When you look at literature and this chronification of pain, we know that all chronic pain begins as acute pain. And when you look at these surgeries like thoracotomy, limb amputation, even simple open hernia repair, the third of these patients will still have pain after 1 year of surgery. So it's very, very bad for the outcome of this surgery. And when we look at the surgical procedure as associated with high estimated incidence of chronic postoperative pain in another paper, we're still having top of the line, we have the coronary artery bypass, the amputation, thoracotomy, breast surgery, and on the bottom we have cesarean section and inguinal hernia repair. So we're going through this pathophysiology and trying to explain and to have some ideas about what's going on regarding prevention and treatment. Another data with more than 7 million patients regarding the different types of surgeries. The incidence is as high as 50% for mastectomy, cesarean section, amputation, 85%, hip replacement for orthopedic surgery, we're having more and more, and thoracotomy. And you look at what is the common factor with these incidents of chronic pain, chronic pain is mainly the surgeries that are involving the most prominent, most extensive nerve network. So this is one of the lessons that we need to think about when we look at the prevention and treatment. Of course, the impact of chronic pain is very important. Sleep disturbance, depression, anxiety. These patients are having very bad quality of life, reduced social activities. So I'm not going to go into all the details, but we know that the impact on the health care in general is very high. When you look at the pathophysiology in general, this is a simplified picture on what's going on the periphery and in the central compartment. You see on the left side of the screen here, we have the peripheral role, where you have tissue injury with the involvement of the cytokine and interleukin-1 beta. Remember this, it's a very important point. And then we have the upregulation of the COX-2 inhibitors, the cyclooxygenase 2 with prostaglandin synthesis, activation of the nociceptors, and from there we have peripheral sensitization, which can lead to central sensitization with involvement of many receptors and many channels. And chronic pain is considered as channelopathy. We have problem with the channels, we have problem with the receptors, and activation of, for example, here, N-methyl D-aspartate, NMDA, the calcium influx towards the cells is increased. We need some regulators of this calcium influx to reduce the central sensitization and the secondary hyperalgesia. And as I said, the upregulation of the COX-2, the cyclooxygenase 2, and the nitric oxide synthetase will also lead to this upregulation of prostaglandin, leading to the central sensitization, namely neural and glial remodeling. And we'll see one of the cartoons showing that these glial cells that are the macrophage of the neural system will be completely remodified, leading to long-term potentiation and chronic pain. When you look at the pain in general, pain can be physiological, can be something positive for our bodies to protect its protective role. When you lose this protective role, especially when you start with surgery, for example, when you have surgery, any surgery will lead to insult on the periphery. All these nociceptors will be sensitized. We will be having all these mediators liberated, and we'll see the prostaglandins will act and will have a very important role in sensitizing all these sensory receptors and primary nociceptive fibers, leading to this chemical soup with liberation of histamine, serotonin, bradykinin, substance P. All these magma of chemical soup will lead to this inflammation. And this is what we call the primum movens, the initial insult, which will lead to then peripheral and central sensitization. So we need to think about that. The other point is that another representation is that in addition to the periphery, what's going on in the periphery, we have this surgical stimulation. This surgical stimulation will lead to stimulation of all the pain pathways, going through the spinal cord, the brainstem, the thalamus, leading to this severe acute pain if it's not treated. There are some interneurons which are created to make the pain, the normal pain, acute pain, severe and persistent. This is the persistency of pain, and the chronification start with here. When it comes to neuropathic pain, with this lesion of the somatosensory system here, we have a different representation with remodeling of what's going on these pain pathways. Remodeling goes through the spinal cord, the brainstem, the thalamus, as you can see it here, and there are some differences with creation of E beta and E delta fibers that are recruited in high numbers, which will lead to this, what we call allodynia, the sensation of something non-painful, which becomes painful. Any touch will lead to a very bad reaction from the patient because of this remodeling of all these pain pathways. When it comes to the higher level, going up to the higher level, I put this slide to show how important is the modulatory pathways. Modulatory means we need to go in the limbic cortex, and we know that the limbic cortex is integrating all these elements of anxiety, depression, pain threshold. All these elements on the limbic cortex will be leading to modulatory inhibitory pathway, which can lead to reduction of the acute pain and prevention of the chronic pain. So this pathway, the descending modulatory pathway, is an important point to think about when we need to be in control of this acute to chronic pain. I will show some examples in the clinical practice how we can do it. As I said, the upregulation of the cyclooxygenase through the prostaglandins, which pass the blood-brain barrier, sensitizing all these glial cells, as I said. The glial cells, which are here a normal picture here, will be modified. You see that they are amoeboid function and picture here. The function will be completely disturbed. They're not anymore the macrophage of the system. They are sensitizing and creating this central sensitization and perpetuating the pain as if it is a pacemaker of pain and pain generator. So are we in control of the pathophysiology in summary of all these pictures that we've seen here? The summary of this is that the transition from acute to chronic pain appears to occur in discrete pathophysiological and histopathological steps. So we have steps of disturbance of all these pain pathways. The stimuli initiating a nociceptive response vary, but receptors and endogenous defense mechanism in the periphery interact in similar manner regardless of the insult. So we can have a small insult which can lead to chronic pain. Chemical, mechanical, and thermal receptors along with leukocyte and macrophage determine the intensity, location, and duration of noxious events. These noxious stimuli are transduced from the periphery to the dorsal horn of the spinal cord with all these amino acid and peptide transmitters activating the second order neuron. And these second order neurons are important, we'll see, in this control of descending modulatory pathway. The spinal neurons then transmit the signal to the brain. The resultant actions by the individual involve sensory discriminative, motivational affective, and modulatory process in attempt to limit or stop the painful process. So this is an important point in the central compartment, the limbic system, where we can control by the preparation of the patient to the surgery, for example, by reducing the anxiety, by reducing the arranging the sleep disturbance and the sleep hygiene. All these can be elements that can help with the descending modulatory pathway to control the pain and the transition from acute to chronic. And normal conditions, noxious stimulation progresses and pain sensation lessens until minimal or no pain is detected. This is normal condition. We have control of the noxious stimulation. The persisting intense pain, however, activates all these secondary mechanisms, both at the periphery and within the central nervous system, that cause allodynia, as we've seen it, hyperalgesia. We'll see how practically in clinical practice we can control the hyperalgesia and hyperpathia that can diminish the normal functioning. These changes begin with the periphery with upregulation of the cyclooxygenase. We've seen it, so we can use anti-cyclooxygenase to control that. The interleukin-1 beta, which is sensitized on the periphery, will be also one of the target of the treatment and prevention. And from the second order spinal neuron, by activation of N-methyl deaspartate acid channels, which is all that ketamine can be one of these anti-NMDA receptors, which can reduce and blunt this sensitization from the second order neuron towards the higher levels. And then we have the microglia, which is altered with the function completely disturbed, which can be one of the targets. We'll see it later. So throughout these processes, prostaglandins and the cannabinoids that we have in our body, ion-specific channels, and scavenger cells all play a role in this transformation from acute to chronic. So are we in control? It's not a fatality, this passage from acute to chronic. So probably we have something to do. We need to do something to help in that. A better understanding of the interplay among these substances will assist the development of agents designed to ameliorate and reverse the chronicity and the chronic setup. So we know that central nervous system changes as pain becomes chronic, with increase of predominance of excitatory pathways with all amino acids that are sensitized, decreasing the dependency of the original nociceptive input. This is what I call the pacemaker, and the sensitization and loss of control, and increasingly abnormal pain processing from the central nervous system. We have also the C fibers that are dying. Their function are being taken by the E delta and E beta fibers with recruitment in high number, which lead to this allodynia. And central changes include loss of inhibition, both via decreased neurotransmitter and also death of this inhibitory interneurons. So it's simply represented as heart disease. Once the cellular damage and cytoarchitectural changes occur, reversing the disease state and normalizing the pain becomes impossible. So do we have statins in our field to block the transition from acute to chronic? We'll see it later. So the question is, why some people develop chronic pain after surgery, whereas others who have had identical surgery, same surgeon, same anesthetic, they don't have chronic pain? So big question. So the question is complex, and this transition is due to risk factors, and there are protective factors, but the issue is somehow complex and poorly understood developmental process involving biological, with all these molecules involved and channels, psychological, and socio-environmental factors. So we have different factors throughout our life that can lead to this chronification. So we start from the birth, and you can see here lots of factors starting from prematurity, congenital disorders. The personality can start from the birth, genetics, and we'll talk about genetics later. In the childhood, the low socioeconomic status can be one of the elements. Hyperactivity. At the adolescence, we have the obesity will start, injuries when we play and we have injuries, and the gender role is important. All changes and hormonal changes and the puberty can lead to this transition from acute to chronic. And the adulthood, of course, we have the multiple surgeries. We'll see some of the examples, overuse of joints and muscles, occupation, chronic disease, and aging. So all these elements can be explanation of this transition. So there are some predictive risk factors for chronic post-surgical pain. First of all, moderate or severe intensity of the acute post-operative pain. So please, if you want to have action on this chronicity and this transition, treat your acute pain. And we've seen in the first slides that we are not doing well. Many of our patients are suffering, and probably we are not seeing them very well. We are not doing auditing. We're not doing re-auditing to see exactly what's going on. So we need to think about that. The other thing that we need to think about is the preoperative pain. Patients who are coming to us already with pain are at risk, high risk of developing chronic post-surgical pain. The repeated surgery and recurrency, surgical approaches with risk of nerve damage. We'll see how we can deal with that. Comorbidities with other chronic pain conditions. You can imagine that a lady with fibromyalgia or a man with fibromyalgia coming to you for any surgery. Imagine the situation with that. Radiation therapy, neurotoxic chemotherapy, and all these psychological factors that are involved, which are sensitizing already the central compartment, preparing the patient to have this risk of getting chronic pain. So the risk factor for us as anesthesiologists and intensivists, when we start to have a patient for surgery, the preoperative factors. We know that moderate to severe pain before, and which lasting more than 1 month. Repeated surgery, we've said that. Workers' compensation sometimes can play a role, and genetic predisposition. The last one is inefficient, diffuse, noxious inhibitory control. This is a very important point, which we call Denneker's. Denneker's diffuse, noxious inhibitory control. Patients who are prepared to have a very strong break of the pain. The break of the pain is this descending modulatory pathway. Some patients, they can break it, they can do it strongly, and others, they are completely reluctant to act. This is very important. And we'll see how in the clinical practice we can do that. We can deal with that. Intraoperative factors, surgical approaches with risk of nerve damage, and anticipation of the pain intraoperatively to block this transition as early as possible. Post-operative factors, we've seen that radiation therapy can be one of the options, chemotherapy, depression, and anxiety. The persistent pain after surgery is a risk factor very quickly. We know the literature is very rich on that. We know that the intensity of acute pain is directly linked to chronic pain. Under treatment is directly linked, and we have strong data from all the international bodies for that. And specific early intervention reduce the incidence of chronic pain after surgery. We'll have some words on that. The pain is nociceptive, neuropathic, or combination of both. This is in addition to complete this complex elements of chronicity and pathophysiology of chronic pain. So we'll go through very quickly through some examples that we all know, but the data is there, the data is strong. I'm going to show some of that. Inguinal hernia repair, for example. In US, we have more than 200,000 per year, mainly for men. It's done in ambulatory setting, but the numbers and the figures are striking. 5 to 30% decrease of quality of life. We used to do it open. Now more and more we have laparoscopic approaches, mesh or no, tension-free techniques or no. So what's the data on that? So the risk factor for the long-term pain after hernia surgery, we have a very nice registry from the Scandinavian colleagues with 2 to 3 years after surgery. They followed these patients, 31% of chronic pain. Risk factors, young age, preoperative pain, post-operative complications like infections, and open repair. So from that, they changed to laparoscopic surgery now more and more. When you look at the another data on 5 years outcome, on the left side of the screen, you have here in blue the open surgery, and in yellow the laparoscopic surgery regarding groin pain and testicular pain. Very, very clear. We have more testicular pain when you have laparoscopic surgery. More. We have less groin pain when you have laparoscopic surgery, and in 5 years outcome, difference is not that high. So, big question, laparoscopy or open? Now the trend is laparoscopy. All the new colleagues, residents and surgeons are doing laparoscopy. It's good for some elements, but we need to think about this testicular pain and ejaculatory pain. This is the ejaculatory pain that can happen in 2.5% after 18 months. So we need to think about both sides to work out all these decisions for surgical indications. And we know that if you have irritation of the testicular part, for example, we have the genital part of the genitofemoral nerve. And if you have more lateral pain, focal pain, is the femoral part of the genitofemoral nerve. If you have a real band, like tight band, we know that it's irritation of the iliohypogastric nerve, and we have clue for that. We can do injections, ultrasound-guided injections for iliohypogastric or inguinal nerve to help with reducing the chronic pain for these patients. The phantom limb pain, this is another point that I wanted to highlight a bit, because when you look at the literature, and I've done a lot of research on that, since the 1940s, 1941, till the years of 2000, 2015, we've done some of work on that, the incidence is around 70 to 80%. Phantom sensations, nearly 100%. Stump pain, 60%. Severe phantom pain, variable, 2 to 70%. Very high incidence of this chronic pain and transition from acute to chronic. These guys are very desperate, probably because of problems, trauma, or vascular problems. So we have to deal with that with precaution. Risk factors of phantom pain, are we in control? Maybe the intensity of preoperative pain, no. Persisting of stump pain, it happens. But we have in our hands epidural analgesia, role of peripheral nerve blocks, which can delay and can not block completely, but at least reduce this incidence of chronic pain with these patients. And now we come to the other important surgery, which it's proactive of pain. This paper, more than 255 patients having general anesthesia and epidural anesthesia, 1 to 2 years after surgery. The results are incidence of 52% for acute post-operative pain, 85%, and the risk factors of having severe post-operative pain and more extensive surgery are predictive of chronic pain. So if patients are having severe post-operative pain, they are more at risk of getting the chronicity, and more extensive surgery, again, they can be at risk of getting chronicity. These risk factors are, after thoracotomy, are on the top is the intercostal nerve damage, but not only that. We have also the rib trauma, the chest wall inflammation, chest tubes, and pleural and lung trauma, which can be a risk factor for that. This is an interesting paper, also with comparing the IV PCA versus thoracic epidural analgesia, looking at the chronic pain at 6 months. And you see that with PCA, which was considered as the gold standard for many years, we have almost double of risk of getting chronic pain after 6 months. Of course, disturbed daily activity and sleep disturbance occur when we have this chronicity. Another interesting paper also for thoracic epidural after thoracotomy, 112 patients, 3 groups, IV PCA, you can see it here in red, pre and post thoracic epidural analgesia in yellow, and only post-operative thoracic epidural in brown. And you see the big difference with higher incidence of chronicity at 2 months and 6 months with IV PCA compared to the pre and post. And the gold standard is to do it preoperatively, continue postoperatively. So avoiding the chronic post-surgical pain after thoracic surgery should be intra and postoperative epidural analgesia, avoiding intercostal nerve damage by doing muscle-sparing thoracotomies, taking care of the retractors, and the closing usually by residents. So we need to think about that, and the outcome depends on how we deal with this final stage of any surgery. Of course, the minimally invasive surgery is a trend now, video-assisted thoracotomies, so it's something we need to think about it. And when you look at this transition between the old school and the new school, transition from the posterolateral versus muscle-sparing thoracotomies, again, the data is there showing that we can have a high incidence of pain with tactile threshold and pain threshold affected in favor of sparing thoracotomies with even sensory evoked potential reduction 38 versus 15 and reflex absent 64 versus 8% in favor of the sparing muscle sparing thoracotomies. The breast surgery, to finish with these examples, important to show these data. The preoperative anxiety and depression, women with maybe bad news because of the surgery. You look at the surgery, mastectomy and reconstruction, 49%. When you add to this axillary dissection, which involves the intercostobrachial nerve, we have typical signs and symptoms of neuropathic pain: numbness, sharp allodynia, hyperalgesia. And when you have even breast reduction, we can reach up to 25% of pain, the chronic pain. Adjuvant radiotherapy can be at risk of getting these patients towards the chronicity. With chronic pain for breast surgery, chest wall and scar pain, phantom pain, this is important, 13 to 24%, and arm and shoulder pain. This is in relation with the intercostal brachial nerve, which is usually cut or dissected by the retractors. The breast surgery, the role of postoperative pain treatment, very important point here. Paravertebral catheter versus IV pain, IV analgesics, results starting at 10 weeks. And the difference here at the VAS score, look at this, 80% versus 0% in favor of paravertebral blocks for this data here. Important to emphasize on the postoperative pain relief in the acute phase in order to help controlling. Again, my title is In Control. Are we in control? We have something to control if we think about it carefully. Other areas of surgery, I'm not going to go into details on that. The cabbage, vascular surgery, gallbladder surgery, hysterectomy, and cesarean section can be also a risk, at risk of having chronicity from acute to chronic. I talked about a bit of surgery, and nerve management point is important. It's a complex issue because sometimes avoiding the sectioning of major nerve is not sufficient to prevent the chronicity. And sectioning nerves clearly does not always result in chronic pain. So what to do? Is it possible to perform operation without injuring elements of the nervous system at some level? Not possible, but we need to think about it. And thinking about it is important. The data is there. Because you have, when you look at the intraoperative nerve injury, maybe the most important pathogenic mechanism. What's the role of the minimal invasive laparoscopic hernia repair, for example, may have also a risk of nerve injury with laparoscopy. Future improvement in surgical technique and knowledge on stapling or non-stapling fixation of the mesh may lead to smaller risk of chronic pain with these techniques. So management of the surgery, nerve sparing nerve, these nerves is important. The sparing nerve needs knowledge, and sometimes surgeons are lost. Hopefully, we are here to help them. So we'll finish with the treatment approach, and there are many elements, many dimensions for this. The first one is psychological dimension. As we've shown in the beginning, the limbic system is very strong on this Denekers, the diffuse inhibitory system, with patient in control of their break of the descending pathway of the pain. Physical, we'll see it, and as well as pharmacological treatment are important. We've published some years ago the recommendation for post-operative pain management in the Gulf region. I was glad to lead this group of amazing friends, led by also the Stefan Chung, who published Australian and New Zealand guidelines, 800 papers, 800 pages of recommendations, amazing work that we've done. And one of the elements, of the 9 elements that we emphasized on, is the chronic post-surgical pain and how to prevent it. All the papers, all our recommendations are evidence-based. You can look at it. It's very interesting paper that can help at the first step in having some ideas about how to block and how to control acute to chronic. Public health measures are important. The phantom limb, for example, reducing the vascular disease related to diabetes and smoking, obesity, especially in our region in the Gulf. It's a high risk factor for many problems. Screening programs are important also to be proactive regarding many diseases. So predicting the post-operative pain, this is a very important point where recent preoperative quantitative sensory testing, QST, could possibly be used as a clinical tool to predict post-operative pain. A simple example, if you take in the preoperative assessment clinic, if you have a patient, you put his hand in cold water. Some people, they don't even accept that because it's very, for them, it's very important reaction, and they show it. And others, it's fine. So this reaction can be quantified, can be done on the research setting to have quantitative sensory testing. And from now on, probably in the clinics, in our preoperative clinics, we'll have some testing that can show that this descending pathway is very important, weak, or not enough important to treat and to help in getting this acute blocked and not to be transient to chronic. This assessment can perhaps guide the use of preventive intraoperative. If we know it, we can do something. Intraoperative, for example, some medication can help. Post-operative analgesia will focus more into that patient, for example. And these patients are identified, labeled before, and then we can treat them. So the last point is the effectiveness of this endogenous analgesic system activated on a previously pain-free state seems to reflect the ability to handle noxious events and might serve to identify patient at risk for post-operative, post-procedure chronic pain. This has been shown by testing the endogenous analgesic system using the, as I said, the Denekers. There are some patients that are strong Denekers and weak Denekers, and finding a positive correlation for the development of chronic post-thoracotomy pain, for example. Some clinical evidence of multimodal strategies, lots of work, lots of trials, lots of paper on the multimodal. The potent analgesia combined with anti-hyperalgesic medication influence the incidence of chronic pain. So we need to think about that. Anti-NMDA receptors can be one of the options. The use of pregabalin and gabapentinoids in the preoperative setting was shown to reduce the incidence of chronic neuropathic pain. And if you can see it here, total knee arthroplasty. So it's very specific surgery. Recently, I'll show it in 1 minute. We have some controversies with some data on that. I will show it. However, other studies on multimodal analgesic techniques with the use of gabapentin venlafaxine and ketamine have not shown consistent results in the prevention of chronic postoperative pain. So we have controversies. We need to think about protocols and specific policies in our hospitals in order to follow and to have prevention of chronic pain. And this paper was published 2012 in Anesthesia and Analgesia, showing that the prevention of chronic postsurgical pain was positive when you use gabapentinoids, and the dots are deviated to the left in favor of the gabapentinoids. It was a systematic review and meta-analysis. Okay, so we have recently, last month, another paper in anesthesiology showing that it's not effective, and these gabapentinoids are not effective. When you look at the paper, this paper specifically, there's something important, which is the heterogeneity, the gathering of all surgeries from different part of the body are not very smart, because you need to be very specific. If you will draw a conclusion, you need to think about surgeries. For example, you cannot compare bariatric surgery with knee surgery or thoracic surgery or breast surgery. The incidence is completely different. So we need to be very specific. We need to be, let's say, balanced in our decision in order to target patients who are at risk of getting chronicity and use these gabapentinoids. This is my intake on that. Ketamine, lots of papers on that. It is well known that it will reduce this enhancement of the painful pathway through the glutamate and substance P, and blocking these receptors, NMDA receptors, will help in reducing the hyperalgesia and reducing the chronicity of pain later on. Gabapentin, the ketamine and amantadine. How do we use it? Very minimal boluses at the start of the induction. Very anti-hyperalgesic. It's not anesthetic dose. Okay, we can use constant infusion. We can mix it with the opioid in the PCA. Very effective. I'm not going to go into details. We don't have time for that. But it can decrease the hyperalgesia, reduce the pain score, and reduce your opioid use. And this is part of this multimodal treatment of this opioid-free anesthesia. Not going to go into details on that, but we know that it can help. It have a prolonged effect up to 48 hours. COX-2 inhibitors, we've seen at the beginning when I showed this, these pathophysiology, that the COX-2 the cyclooxygenase 2 are upregulated in the central compartment. They penetrate better, the COX-2 inhibitors penetrate better the blood-brain barrier and should be more efficient analgesics. So we need to base our treatment baseline on these molecules in addition to paracetamol, and then on the top of that we can build other modalities to help with that. Magnesium can be one of the options. Intraoperatively, it is a natural NMDA receptor blocker, can be used adjuvant analgesic, and it can help in chronic pain and hyperalgesia. The bolus is 5 to 50 milligram per kilogram. So in summary of these molecule-based treatment, this diagram, which I took from one of my friends, courtesy to him in Canada, who showed this slide showing that we can act on different parts. COX-2 inhibitors in this part here, prostaglandins, local anesthetic whenever it's possible. We need to ask our surgeon to do it. Anticonvulsants at the primary afferent nerve fibers receptors, alpha-2 agonist, and a tricyclic antidepressant can be of good use also. Opioids and acetaminophen, which is called COX-3 inhibitors, showing that it can be effective on nitric oxide receptors and GABA receptors. So this multimodal effect of our acute pain can help in reducing this channelopathy, and these receptors here are blocked in order to block all these neuromediators leading to central sensitization. So future research to finish, the role of preoperative pain is important. Neurophysiological and psychological assessment in predicting chronic pain. When we see patients preoperatively, sometimes we see, oh, this patient is going to be difficult because we feel that psychologically he's unstable, and the assessment and more accurate assessment should be done. Effect of intraoperative handling of nerves and muscles. This is the role of our surgeons and friends from the other part of the blood-brain barrier. The central and peripheral nervous component in chronic pain is the basis of the prevention, and genetic makeup could direct the treatment. I'm going to finish with these genetic factors that are important. The animal work has shown that genetic factors influence this development of chronic pain after nerve injury. And in the clinical setting, in the human setting, we know that fibromyalgia, chronic migraine, irritable bowel syndrome, irritable bladder, back pain, and Raynaud's syndrome might have an underlying genetic predisposition of developing chronic post-surgical pain. So genetics, still a big field, but we are in control of those patients who are, as we said, dysfunctional pain, or nociceptive pain, we call it now. So these patients should be taken into consideration, and these pathologies should be taken into consideration more carefully. So the final thought, acute pain is an important part of our warning system and healing process. Persisting post-operative pain starts out with a significant inflammatory and neuropathic component. So gathering these signs and symptoms of neuropathy post-operatively is very important. Anything related to allodynia, sharp pain, tingling, all these elements are important to be proactive. General anesthesia only uncouples awareness from peripheral noxious stimuli, and peripheral sensitization can still occur, causing chronic pain. Certain populations have a higher risk for developing chronic pain, and all chronic pain starts as acute pain. Remember that. So take-home message, chronic post-surgical pain is a real issue, high incidence of sleep problem and quality of life. Treatment is crucial. Nerve damage seems to be a major risk factor. Surgical techniques are crucial for prevention. Many potential facilitating factors to be tackled: preoperative pain, depression, postoperative complication. And the multi-O model, or multidisciplinary approach, multi-dimensional approach is the key. It's not only pharmacology, it's physical therapy, sleep hygiene, lifestyle management, stress management, interventional pain management if needed, biofeedback, education of these patients, and complementary therapy if needed. Thank you for your attention.
Thank you very much, Dr. Amar. I would personally like to thank you for the informative, collective lecture. Honestly, every time a question pops in my head, I find it answered in like a couple of slides later. I think this is why we don't have any questions for you. You honestly, everything is there. You answered every single question popped in my head. The phantom pain, like the categorization of surgeries, it was like collective, informative. Thank you very much for this. Thank you for the presence with us today.
Yes, sir.
I
Comment, yes, sir. I know he's in chronic pain.
thank you very much.
Thank you,
Dr.
Dr.
Ammar,
Ammar. I have
that's
a
excellent
question.
lecture.
Yes, please, go ahead.
You know, really, you make something very difficult. You are a star as usual, but you make something very difficult, very simple, but not simple to such simplicity you discuss, because we don't know anything about that. And all what you said is just an try to explain is very good. But I have really, you know, we know that chronic pain is not continuous acute pain. This is different in everything. But you know that you speak about the surgeon, and this is a major part of to prevent a chronic pain, and we don't have a power on this surgeon, because most of the time the surgeon refusing that. We have a problem with the orthopedic surgeon. How you solve this issue with this surgeon?
I believe in hammering, you know, being behind them. I, I can tell you, I was in a hospital. I just started there, and they told me the medical director is a big surgeon, pediatric surgeon, very nice gentleman, very efficient, very good surgeon. And I did once a lecture, and I talked about local infiltration, simple local infiltration. And that's it. I think a week later, I was doing a case with him, pediatric, and he looked at me and said, look, I learned from you this. And he did local infiltration of a hernia of a baby. And I think it's to be consistent and to be persistent on that. Our new surgeons are now colleagues because we know them and we friends, and we can discuss this. And the evidence now is there. Everybody's thinking about the era of evidence and strong evidence. You can just show the recommendation from the American Society or European Society or the Gulf Society. So you can, I think it's feasible. And I think it's small links that you can attach together. And we as anesthesiologists, we know how to do that. We have the ability, and we are very flexible, and we know how to go around the corners. I think it's feasible. I did it, so you can do it.
Second question, Dr. Amar, you said about to predict which patient can get the chronic post-operative pain. But why don't do our strategy to prevent that in all patients without prediction? Because you don't know who's predicted to have a pain or not.
That's true. Good question. Very good question. Actually, we talk about statistics. When we see the statistics, for example, surgery that needs to be really taken into consideration very carefully is thoracic surgery. We all know that we do thoracic epidural or paravertebrals for breast surgery. We focus on that. Why not focusing with every surgery? No, we focus on that because the incidence is very high. You know, for hernia repair, now it's done with laparoscopy. Nobody's thinking about testicular pain, for example. And they end up coming to our setting, and you do these genitofemoral blocks and things like that to help with that. So you cannot generalize, but you can target to catch at least the maximum and to be effective on this high incidence of patients. You cannot do everything, but of course, the ideal is to think about psychology, to do these QSTs before surgery, during the pre-adjustment clinic. So all these elements are important. You're right.
Thank you, Ram.
Please, the question, Dr. Ammar. Can we
Yes.
categorize a type of operations, for example, laparoscopic surgery, knee surgery, or orthopedic surgery, total hip or total knee, to be pre-emptive use prophylactic painkiller or pre-emptive analgesia before?
Yes, this is what I was alluding to when I talked about antineuralgics or gabapentinoids. We need to focus and to target and to really choose the surgery that are really leading to chronic pain. We know that the network of nerves in the knees is important. So even the approach of the surgeons when they do the TKR is important. The medial approach and the lateral approach, they're different in the incidence of chronic pain. So this is important for knee, for example. For bariatric surgery, I saw some of our colleagues doing, for example, awake bariatric surgery, or doing thoracic epidural for thoracic surgery. I don't think that will, for bariatric surgery, I don't think this will lead to any improvement of the chronicity or the acute, even the acute pain. We need to be specific, and we need to have to follow these the recommendation of the prospects, which are based on recommendations and evidence, strong evidence for every surgery. And the website is very easy, postoppain.com. So you have all the surgeries with all the recommendations, and it's evidence-based and managed by the European Society of Regional Anesthesia and American Society of Regional Anesthesia. So surgeries are important to be stratified first. Patients at risk when they need to be high attention, and we need to be balanced. We need to help to tailor our analgesics according to that. For example, pregabalin for simple, appendectomy, pregabalin preoperatively is not preemptive anesthesia. It's provoking dizziness, nausea, vomiting. We don't need it. But If you have a patient with chronic pain before, fibromyalgia coming for totally replacement, definitely I will do regional anesthesia, I'll do pregabalin before, and do all the multimodal during and after surgery.
Thanks. Thank you very much.
Last request, Dr. Amar, if you don't mind, one of our colleagues asked you to write just the website for the
Yes.
pain things
Yes.
on the
Prospect. If you Google Prospect, it's amazing. It's amazing website. You have everything in it. Everything. You have like all surgeries with preoperative, intraoperative, and postoperative recommendations, and highly recommended.
Mm.
Along with the recommendation of the the Gulf Pain School and Society, which we published some years ago.